campaign, but I have been trying to spend a lot of time in the last 2 months going into this on behalf of this church, which I belong to, Queen's Park Residents, which has also addressed these issues. And I've got some wider concerns I'd like to raise, but as we've talked a lot about central Middlesex, I'd like to come in on that. I mean, what seems very, very puzzling is that 2, 3, 4 years ago, large sum of money, I believe 70 million or so, was spent on improving and putting new facilities into central Middlesex. So as a building, it looks rather splendid, and to go into it, you feel comfortable and you feel, gosh, this is a modern place for medical care. And then you discover, you know, that there's very little they can do in terms of an emergency. So somebody from this church, actually, with needing stitches, and her nose was taken in after just before coming to service, and she had to then be taken to Northwick for the stitches to be put in. Now, how does it inspire confidence in the overall judgment of NHS North West London that's putting this forward, if this huge sum of money was spent improving these facilities, and all these issues about how specialists need a good turnover of cases, etc., doesn't serve a big enough population, and all the other negative factors that you've introduced about central Middlesex, all this must have been known. So why was this great sum of money spent when you knew that the facilities were, in your view, unviable? I mean, it doesn't inspire confidence. And I mean, related to that, this document is called Shaping a Healthier Future. The strategy of Brent CCG is reducing health inequalities. And it's clear that the inequalities are in this part of Brent. In other words, people have a lower expectation of life than those in the north of Brent. So, what has already been happening in central Middlesex, let alone what is proposed here, is reducing, the healthcare provision for people in this part of Brent. And so, how can it be consistent with this strategy? And how could this be a correct name, for this document? In answer to a question put to you by the Kilburn Times, Dr. Spencer, this week, you said that people with greater travel distance will, at some extent, at risk. Research shows the increase is only 1% for every 10 kilometres travelled. But that is an increase. So how many people might die or have severe trauma that wouldn't if there was a properly operational A&E department at central Middlesex? And why is there no risk assessment for this whole operation available for us to consider?
So, two questions. One is around, was it sensible to invest in central Middlesex a while ago? That wasn't done by NHS North West London. That was in the days of Brent and which structure the NHS was around.
It was the Brent and Harrow. But the other
NHS?
Yeah. No, the other thing is you want to bring in elective to use the space at central Middlesex for a centre. I think we had a discussion to make it into an elective centre of excellence for planned scheduled care.
That's a proposal.
No, it's happening.
Yeah. So I mean, your first question was
expanding. Yeah.
Your first question was
within the document. It's a proposal, but should change central Middlesex. But we all know that the A&E there is not fully staffed, and it can't do very much. It doesn't operate 24 hours, and many people have sort of written it off. But they're deeply unhappy about this, and as people have already said, the travel times to Northwood Park are long, and it is congested. The roads are congested and winding. It's not a swift transit. Now, I mean, it may be worse if you live in the Isles of Scilly or in the Shetlands or something, but we're not talking about London. So I think we're talking about reducing health inequalities. And I can't see how the proposals would help to do that.
Let me come back to that. So I can't explain why there was investment in central Middlesex. The local residents would have approved of that. What we're saying is that investment has been made, therefore we must make very good use of those facilities, and that's why making an elective hospital makes it useful. It is at PFI, it does have a large mortgage, we need to pay that, and to do that you put a lot of activity through it, and making an elective centre makes it a sustainable hospital, which means you can stay in that place, and it doesn't have financial risk associated with it. So we're trying to make use of that process by doing that. So that's central Middlesex. The second part of the which is much more important, is around inequalities coordinated primary preventative care, and that's what makes the biggest difference. So it's the investment in general practice and in community services and working with social services that makes the biggest impact. And actually what we're trying to say is we don't want to, at the moment in North West London, we're spending a lot of money on hospital buildings. What we want to do is spend that money on nurses and doctors and caring for people to stop them becoming ill. If you look at diabetic care, 80% of the spend on diabetic care at the moment is in treating people who have complications, which if they had better care earlier on, they wouldn't have any of that problem. And you can make those investments improving that. And that's, so what we're saying is, actually, we've had an initial health impact assessment, I think a much fuller one will be done before we have make any decisions.
But why not now? Why not with it as part of the
So the initial, because the initial one was so favourable that said actually improving out of hospital care has such a big impact that it is going to have the biggest impact on those people who are living in deprived areas where there are health inequalities.
Yes,
I'm going to move it on to the line.
Dr. Spencer's introduced out of hospital.
I'm sure we'll come on to it. I've got 4 people waiting, so I'm going to move.
Well, that's part of what I want to raise. So he's answered my question in a different way. He hasn't answered.
We won't come back to
with respect, you're facilitating, but he hasn't answered the question, what is the increased risk to people?
Okay, so very brief response.
How many people are going to suffer?
So the increased risk, so there's one paper by Professor John Nichol that describes a 1% increased risk of people who are unconscious from respiratory arrest if they travel for over 10 kilometres. So this is a tiny subset of people who have to travel over 10 kilometres, and in fact there are other papers since that have refuted that and don't show that, and that's because of the increased use of oxygen and paramedics. That paper is...
So your answer is none.
Hang on.
You're,
I haven't said that. There are other papers that don't show that increase, but he suggests that's a small increase in that paper. There are other demonstrations that actually if you have improved consultant cover in larger hospitals, that has a much bigger beneficial effect that outweighs any small risk you have there. So if you just look at the risk of going to a hospital that doesn't have support from surgery, as opposed to going to a hospital where there's support for surgery, there's a 7% increase in mortality. So that's a much greater risk in our current system than any potential risk we could do there. We are doing a much bigger piece of work, looking at all the evidence which will be available for people to take decisions later. But we're quite content as the clinical leaders, we've looked at enough of this detail that we're making a safer system, not a less safe system.
Yeah, my question, I spoke to you before about schools and governing bodies of schools and so on, not being consulted on this, although I would think the children are major stakeholders. I'm a school governor and a former teacher and a former first aider in the schools. I'm concerned with the rising school population in this area, immigrants in general, that we're losing a facility readily accessible to schools, first aiders and so on, in the local area. I'm even more concerned, though, about what we have been doing, because you said indirectly, and Dr. Khan directly, quite a bombshell, because you said that Central Middlesex A&E is unsafe. You've actually just said it's unsafe. So we are sending children we are sending children to an A&E which the practitioners say is unsafe. We are putting them at risk. And if that's been going on without you doing anything about it, then that is a scandal. Because when it comes down to it, we've hardly mentioned it, but in all this, what we're most concerned about is that you're putting people at risk with the new proposals. If Central Middlesex is unsafe, A&E, why is it that most of the redirections that come from Northwick Park when it's under pressure are being sent to Central Middlesex? I mean, that seems absolutely appalling.
Can I answer that? When I'm saying, if you look at now, the night service of Central Middlesex has been closed because it was unsafe, because they could not recruit effectively, efficiently qualified
so
staff.
So day service is safe, do you know? The day service you think is safe?
Yes.
Despite what was...
No. So if you give me time to explain, it's a consultation, it's a two-way traffic, right? So you ask me why I say it's unsafe. The night services over the night is unsafe because due to lack of trained people applying to the jobs to work for the night hours. So that's why I was saying it's unsafe.
So if I can, Dr. Spencer listed paediatricians and a whole lot of things that didn't exist there.
So, no, I agree. So if you ask me, well, I would take a child, I would tend to take it to a place where I know there's a paediatrician on site. I haven't got evidence that mortality is worse at Central Medicine elsewhere. As teams of doctors, we have looked, there are models elsewhere in the country where you have an A&E that doesn't have support from those places and they transfer them off to paediatric unit elsewhere. In London, where the distances are relatively short, as clinicians, we don't feel that's the best model of care. We would much rather, and our recommendation is for every A&E should have a full range of services behind it. Central Medicine
My
doesn't.
question to you, Dr. Spencer, and I think it's really important, is that you've got an accident at the schools. A parent's talked to us today about a child having a violent food allergy, going blue, needing A&E. If that happened in a school, they'd take them to the nearest A&E, probably in the back of the teacher's car. You're telling us that if they got there, essentially, that's important.
So they would stabilise the child and call an ambulance and take them to paediatric.
Like Mark says, you can still go to Parkway A&E, but you will treat it. But overnight stay is not possible. Yes.
They would
Yeah, the acute care will be taken on immediate, but it's the aftercare.
You know, you said that the
Hang on,
the night
hang on, Greg, hang on.
was
We've got
temporary.
3 people
When's it
waiting.
reopened?
We've got 15 minutes left. So I'll come back to you if I can.
I think we're prepared to stay for a long time because of our health that these doctors.
But before I ask the next question, I'd like to one or two people look at this gentleman here. Could you just like briefly introduce yourself?
Yes, sorry. I am the clinical officer for 4 clinical commissioning groups in outer northwest London, including Brent. So my name is Rob Larkin.
Chief manager.
Yes, so my job is to work with support the clinicians in regards to the programme of change that we're talking about today. That's why I'm here.
Are you listening to us?
Listen to everyone.
So the fact that all patients locally are against it, you will take that back, will you?
Not all patients.
Not all.
Which patient is in favour?
Let's be polite to everyone here and move on to someone who's been waiting a long time to ask a question. Stay in the front.
Just wanted to ask in terms of how the proposals that have been put, how is it going to support the GPs? As you know already, GPs are under severe pressure with the new integrated social care and the PCT that's going to be overburdened on them. And you can't hide the fact that every GP in Brent is like under pressure with anything, referrals, the time, so it's all constrained. And I think sometimes the public are not really actually getting that impression that they don't have the time, or it's not about they don't want to do it, is that they've got financial restraint, they've got other things they need to do, there's a set time, they're there. So how, I'm just wondering, in terms of making it very practical to the community and locally, so that people are on the mentality of what they're going through and what requests they have from the GP. How is this all new integrated care going to facilitate and help the GP psychologically that he's not under pressure and is not affecting the community in a bad way, or that when the patient is going to the GP for help, he's going to, like in terms of they're going to have an argument, or it's going to be some kind of vicious circle that you don't get that communication-wise, you get that wrong impression of why is he treating me like this. But as you know, it's not his intention, but the way they get positioned and the way that the position of the today meeting, that's totally different. And I think it gives a really bad impression. But I'm just saying, in terms of all of this being okay, always in the brochure, your GP can provide it, whereas practically we can't, you know, it's something that is literally blue and black. So how can this proposal help facilitate the GP so they can provide the care as they wish to the patient, so not having the kind of that communication?
I'll answer the issue that I have, so I think it's most of that I know how it works. So certainly GPs are under a lot of pressure. I'm a GP, I know what it's like. They're busy people, and the workload in general practice has increased hugely. In my practice, we offer twice as many appointments now. We have the same list twice what it used to be. They're all still full and still people complaining they can't get in to see us. We're doing twice as much work. I'm fully aware of that. What this does is it says that we need to invest in those services. In London, typically, we've tended to invest in hospitals, and rather than investing in general practice, we go outside of London, find patient satisfaction is higher, and that's normally because they've invested more in community than general practice, and they're spending less of their money on hospitals. So part of the plan is here to invest in extra doctors, to more GPs, but also in the skills of people in practice. A lot of the people I see are better off dealt with by practice nurses. Some of the people that practice nursing are better looked after by healthcare assistants. And in the past we haven't had a good scheme to train healthcare assistants. We haven't had a scheme to take nurses who are generally trained in hospital and train them in general practice where the skills are very different. We've been working with the people who train nurses, train healthcare assistants, so we can have more of those people working in the community, more social workers working alongside GPs. So a lot of my time is spent trying to sort out social problems and coordination problems. And in each area, I find that GPs and GP networks are employing people to help that coordinated care, which allows me as a GP to see the sick, complicated elderly particularly, and manage other people to do that. It means I have to change the way I work. Some GPs don't like that because they're quite used to the struggle and get under. What we're trying to do is relieve the pressure from them by redesigning the team around to help them cope with that.
I want to thank you for understanding the pressure that GPs are working under. Thank you very much. What we need to do is, as we know, we all like our practices the way we are. You told me earlier about which one is your practice. So sometimes, like you said, over the years, the demands and the expectations and the type of care we've been providing have to change. And Mark mentioned earlier on about networks. So we have to be smarter in what we do, delegate to the right people, signpost our patients to the right places. So, for example, that Mark mentioned training. We are now looking at the training in order to upskill our community and retain the people to work in the area. So I'm saying that is because my practice is a training practice. We are not now only training GPs to be GPs, we are training nurses now, we're training healthcare assistants, we are also training nurses who are switching from secondary care to primary care because you cannot make a direct transfer. So we are trying to address the training issues of the skills that we need in the area. And working together, and Councillor Hunter will back me up here, is that we have now worked with social services very closely in an integrated service called STARS. Yeah. And for some of us who have loved ones who have used the service, it has been a very good integrated care between health and social care, utilising the right people. So what you say is not the GP caring all the time. So within that scheme, we have community nurses, social worker, occupational therapists, physiotherapists within the team to look after the care of the patient where it is most appropriate. So you will see a difference in how practices give care to the patients. So we need maybe to communicate the change in different things we do in practices, who you should see for certain, let's say, dressings. It need not be a doctor. Vaccination need not be a doctor. Managing diabetes might be another doctor, not me. So I suppose you were saying that we have to communicate clearer to our patients in our surgery who does what in the practice. And also the other thing about networks, some of us are smaller practices, some of us are bigger practices. So we are now learning to share our skills within practices, neighboring practices. So if I can't do something, a practice down the road would be able to provide the service for my patients. So that's another change you see within your practice area.
So just a couple more general points, if I may, and there's some really good questions there, because what we do there is what can make the biggest difference to help local people is the quality and capacity of primary care. And as we move forward, as the needs of the population changes, people are getting older and living longer with long-term conditions, it's really important that we invest appropriately in primary care. As Mark has already said, none of this is about cuts. The investment in the NHS services more generally is going up and will have gone up by the time we finish this programme.
There's £1 billion funding gap, Mark told us the other night. You are cutting £1 billion because of the demand.
I'll explain. So that's a good question. So I can
Well, it's in your document.
Yes,
There's £1 billion
there's a
funding
funding
gap.
gap. So if you compare the rate at which the NHS's funding is going up and the pressures that that funding is going to have to accommodate, there is a gap. But that doesn't mean that the absolute amount of money going into local services
But over time,
is going
can
down.
be a
It
huge
doesn't-
cut. And that's what Dr. Conley is supporting, which is why we think our GPs
So if I could just
are
finish.
against us instead of for us.
Just let Rob finish, and we've only got 10 minutes.
What's really important is that we make some decisions about priorities for investing NHS money in services going forward. And what these proposals suggest is that it's really, really important to invest in local primary care, in out-hospital services to meet the needs of local people. So we're not cutting anything in primary
Well,
care.
you
We're not
haven't been
cutting
anything
anything
to
in
Dr.
out-hospital
Spencer, because
services.
you've been saying that every meeting.
Okay, we've got 10 minutes left, and I've got 4 people who haven't asked a question yet who'd like to ask questions. Move swiftly on. Can I just check you're okay with that?
Why are you ending the meeting so early?
Can I just, I'd like to ask a question. Are you quite sure that the support of local GPs for this scheme is quite as unanimous as the impression was given earlier? I was quite surprised when I went to my local GP in Dollis Hill. I said, can I give out these petitions against the closure of Central Middlesex? She said, yes, please do. We GPs have not been consulted about this at all. And I've just come back with over 100 signatures which were given out with the consent of the GP and with the assistance of the staff in the practice. So I am by no means convinced that many GPs support this scheme.
So, I mean, I can't answer for your particular practice. Certainly, as I talk to GPs around the area, there are certainly some GPs who are very anxious about any of it. The majority of GPs understand entirely the case for change and the need to concentrate services onto fewer sites. And that was completely true when I talked to hospital doctors. They're very strong supporters of the case for change. They're much less convinced when they're asking whether it should be their local hospital that changes. Certainly in some areas I go to, there's unanimous support in every practice has signed up and has voted and confirmed they agree with this. In other areas like Ealing, we're going to have a balance of our GPs to confirm.
Why does my GP say she wasn't consulted at all?
I certainly don't know about your GP. Certainly in Ealing we've been having meetings with the GPs about this for the last 18 months.
I don't believe any GPs in Brent support this, but if Dr. Com knows any, perhaps you'd be kind enough to share the names
Let's let Dr.
of the
Com
GPs in Brent who support her proposals.
Okay. As you know from the document, there are 5 localities in Brent. And the 5 localities are served by what we call clinical director, who is a senior GP from each locality. As far as I'm aware, all the localities, you are in Wexbury is Kilburn, isn't it? In the locality in Kilburn, yeah. And that will be under the leadership of Dr. Amanda Craig.
We know about it.
Yes, and for myself in Harlesden, it will be me and Dr. Ansari. I'm aware, unless my clinical directors tell me otherwise, that this has been discussed at the local GP networks, at the clinical forum, where all the GPs come together.
Which GPs support it in Brent? Can you tell us that?
All the GPs have signed up to the constitution of the CCG.
Yeah, that's a constitution.
Yeah.
This proposal to destroy our health
yeah.
services in the whole. Which of our GPs, apart from you, support it?
Some of us are waiting, and some people are...
Yes, exactly. Thank you very much.
I don't want to answer the question.
Thank you.
That you have no support from GPs.
I've got several people waiting who haven't asked a question yet, so please.
So can I just...
Get the consultant doctors to answer the questions that are being asked.
She's trying to
It's a
answer.
simple
Yeah.
question. Which Brent GPs support you, Dr. Cole?
Okay. We have 5 localities. I repeat, we have 5 localities with 5 clinical forum meetings every month, where all GP practices are welcome to. Nurses, doctors, and practice managers are welcome to those meetings. This strategy, shaping a healthier future, has been discussed at all the GP